if it won't video to audio, but it should be. It's recording, so be careful what you say.
Angela, you're not going to be able to do that during the Skype session. Okay?
Do you want it clearly or hot? Ever satisfied, typical woman you are.
Well, I'm glad you didn't say anything else. Add any other adjectives to that word once.
I mean, I thought of you, but
I know you did.
Just erase the board.
you just mind your business, Chelsea. I'm just trying to help out. Did you go look at your car?
I'm focusing. That was on lunch or whatever.
Are we fixing to start?
Yes.
Because I need to record.
Well, I need to fix my hair real quick. Am I going to be able to?
Oh, yeah, me too. Here, hold on. There's soda. Why do you have to put my iPhone on charger when we got like 60%? That's good earlier.
Why are y'all recording when she put it on YouTube?
Because I'm not getting on YouTube. I can listen to this in my car while I'm
I was
driving.
just asking questions like, bro, what's the answer?
Maybe people and they
Yeah. She trying to make it accept the thing she thinks it is.
go back you with the What? I'm trying to make sure I put my recorder on.
Miss King, who was that?
Who is Tyra?
Yeah.
Tara. Oh, my legs start to hurt like this.
Up and down, up and down.
I don't ride like that.
Bye.
Can y'all push the button there? Is it almost done?
We'll push the button.
Yes, she's going to be able to see you.
No, she can't.
She can see us. She can see me. She can see you. Say hi, Chelsea.
So see, that's what I was gonna do. That comprehensive. But I want to do it all at once and see what it makes.
I wrote mine up in the 3 days.
So is she gonna be like putting on like PowerPoint?
I guess. We don't know. I think so.
If they were, when you walk
Not
back there,
throwing
would
that
you
spark
throw
stuff away for you because you have a problem and you drink too much spark.
Spark is good for you.
No, it's not.
it is.
Tell it up. Tell it other thing you like to do. No, it's just a joke between me and her.
She said either she put in her time, I said I can either use spark or be nut.
So listen, I said, so when she scared me, I'm like, oh shit, you tried meth before? She's like, no, but I'm just saying, either one.
That was that okay.
You scared me for a second.
Sorry.
Does it taste nasty?
Do you want to taste it?
I don't.
In high school, I was a little bit chunky. I actually was chunky a few months ago too. That's why I
You use the spark?
No, yeah, well, it's not for because it's for the spark. Yeah, I guess kind of like I take it for a workout.
Oh, I don't work out.
Like in high school, I lost a lot of weight. I was super skinny and I like my whole
When I got super skinny and this boy told me, he was like, you look good. You know, you like candy, smoking crack or something. I don't know if that's coming or she's late.
2 minutes to be exact.
Angela, can you undo this password? What? Huh? Oh. Yeah. So my lock code is not at all. Oh, I don't have a lock code. So when it starts, push that button. When it goes back to regular, it's on here. When it starts.
I forget sometimes, so can you just like shout out, be like, Angela?
Huh? What? Man, I'm not bringing your phones back. You gotta put a little of that pipe down in your voice. I'm going. I don't know who actually thinks you're talking to.
They need to start making these boxes. Okay. Are we going live?
She's recording
Oh, that one's going on YouTube. Should we lift this up then?
Tilt your screen back up. Tilt the whole screen.
For a small fee, maybe like the 75% guarantee on the ATI. You wouldn't hold it up to 1%? Oh yeah. The guarantee is 75. I would. I'm gonna go ahead and just help you out a little bit, okay? Okay, I got you.
You got it.
Is that me?
What'd he say?
It's a phone number.
Oh, no, sorry, baby.
I think I got it.
Yeah, can we turn that ring off?
If it's not my phone, it's my phone.
Yeah, but it's not.
You can just put it on the side. Maybe we could see this camera. I think I may have had a solution. Not yet. Not yet.
Okay, I don't appreciate that camera.
I'm sorry, Shanika. I couldn't help it.
Is it recording?
Oh, it's been on this whole time?
It's because it says relationships and this is nursing school. This one says driving.
Miss King,
Yes. Can you hear me?
I can, but I can't see anybody.
Okay. I think I might have answered it with just audio.
Alright. I talked to you for a second there, but then they went away.
Yep. Let's hang up and try it with, or well, I don't know if it'll let me do video. Let's hang up and let me call you back with video. Right front and center, darling.
Where's that camera?
Chelsea?
No, listen to myself. You come here.
Angela, don't forget.
Got you, boo.
See you? Can you see me?
We can see you.
We can't hear you.
Still see me.
Turn it up.
It is that.
It's all around.
Y'all are gonna have to be quiet. It means you're gonna have to calm down.
Speak louder.
Yes.
Yes, you can hear me? Yes, it is. Speak louder.
You need to speak louder.
Okay. So we yell. It's like you do.
Okay.
Angela, put my phone on speaker.
It is.
So I was asked to help you review some pharmacology. Is that why we're all here?
Yes.
Agreed?
Yes.
All right, I provided 2 handouts. Do you have the handouts?
Yes.
So the first handout is sort of a PowerPoint, and the second one is boxes that you can fill in.
Everybody have that?
Yes.
There's a PowerPoint and then the one with the blocks you fill in.
So we're going to go through the PowerPoint together. The one that has the boxes that you can fill in, this is a tool you can use if you desire. I have used this in several classes, and students usually give us pretty positive feedback. So these are the areas you need to understand about the medications we're going to talk about. You need to know what the med is, what you're going to use it for, or what effect you hope to get by using that drug. What are some examples of the drug? Because on the NCLEX, it's not going to tell you that they're taking a beta blocker. It's actually going to use the word atenolol. So you need to know that that is a beta blocker. You need to know anything you need to administer the drugs, what you need to know after you give it to keep the patient safe, and then any patient teaching that needs to be given so that you can help the patient take the drug on their own safely. Everything we talk about today is going to reflect patient safety. I cannot go through every single medication with you. We just don't have enough time. But what I have decided to do is look at the medications that you will find most frequently in your practice, and therefore will be most often on the NCLEX. NCLEX is really focused on what you will do in your first year as a nurse. And these are the medications that you will most likely see. Everybody okay?
Yes.
All right. I can see some of you, but not all of you. So if there's a question, raise your hand, signal, yell it out, stop me at any time. All right, we're going to first start with some diabetic medication. In your educational experience, doing your clinicals, have you all had an opportunity to give medications to a diabetic patient?
Yes.
Is that a yes from everyone?
Yes.
I imagine everyone's given insulin?
Yes.
All right. Very common medication. So what do we have to know? Let's start with what is diabetes?
Are you asking us?
Yes.
Oh.
Anybody can tell me what diabetes is?
It's a disorder where your body doesn't produce enough insulin.
Okay.
What did you say?
Or metabolized glucose.
Or it doesn't metabolize the glucose.
Okay.
Are we on the right track?
Those are not incorrect answers. So when I like to teach diabetes, I think of it's about a cell and about glucose trying to get inside that cell. So let's pretend our cell is a garage. And the glucose is your car that needs to get inside that cell. So in order for the garage to open, you have to signal it, right? Using a garage door opener. Insulin is the garage door opener. Insulin signals the cell, allowing that car or glucose to come in. That's the normal physiology of how our cells get glucose. And the cells need glucose because that is what they use for energy. It's their food. In type 1 diabetes, the pancreas does not produce insulin, or does not produce an adequate amount of insulin. Therefore, you have all these garages sitting empty because you can't get the cars in. And if you can't get the cars in, then you have all this backup of vehicles on the highway who can't get into the little garages. Or all these cells that are starving because they don't have any glucose, because the glucose can't get in without the insulin. So in type 1 diabetes, you have starving cells, lots of glucose sitting out here, and so your serum glucose levels are high, and the patient is hyperglycemic. Although your cells are starving and telling your body, I need more glucose. Eat more. So the body says it's starving even though you have tons of glucose floating around. So our treatment for type 1 diabetes is to give insulin so that all this glucose sitting out here can get into the cells. So that all these cars can get into their garage. Does that make sense to everyone?
Yes.
Type 2 diabetes is a little different. Type 2 diabetes, the pancreas produces insulin. But what happens over time is you open the garage door, the car goes in. You open the garage door, the car goes in. You open the garage door, the car goes in. You open the garage door, the car goes in. And that occurs over and over and over and over and over and over and over again until the cell says, whoa, I'm tired, and it does not react to the garage door opener anymore. So type 2 diabetes usually occurs over a period of time, usually due to poor nutrition and a lack of exercise. It's a metabolic problem. It's not an insulin problem. We're flooding our bodies with all of this food and sugar, and the insulin keeps pushing it into the cells, and over time, the insulin becomes ineffective. Just like if your garage door opener ran out of batteries. The door is no longer going to respond to that insulin. So, in type 2 diabetes, if we gave insulin to our patient like you do in type 1, it's not going to help. Because it's not a problem with insulin. It's a problem with the cell wanting to accept that glucose or understanding the signal it's getting from the insulin. So in type 2 diabetes, we often find that changing your diet, changing lifestyle can help. And for patients who are unable to control their glucose with those actions, there are medications which impact the cell and the ability of that insulin to have the sugar into the cell, or the glucose. Some of our medications we'll talk about also create more insulin being produced by the pancreas, because the pancreas works just fine, to try to flood the cell with insulin, hoping that if we try all sorts of remotes, one of them will work, and we'll be able to get the sugar in. So those are the types of drugs that you use for type 2 diabetes. So understanding the difference between the two is essential to understand why you would use different treatment options. We don't want to just memorize. Having an understanding will help you remember and be able to apply this. So we did a little patho review. We know our normal serum glucose is somewhere between 70 and 100. So most of your hospitals today are uncomfortable with patients who have blood sugars in the 70s and 80s, especially if you're diabetic. Hypoglycemia is much worse than hyperglycemia. So you may see different ranges when you go to your hospitals because they don't like the patients who are too low. We also have a hemoglobin A1C. Who can tell me what that is?
It measures the glucose or the how you maintain the diabetes for 3 months.
Excellent. So that's not an indicator of what your blood glucose is right now. It's an indicator of how well you have been controlling your glucose over a period of time. So it's a good indication if our patients are compliant or following the regimen that we set for them. So we talked about diabetes type 1 and type 2. Secondary diabetes is if a patient has high blood glucoses or can't manage those blood glucoses due to a secondary or another disease process. So there are several diseases that might create the body to produce more glucose than normal or pull glucose out of stores. When that happens, they may look like they have diabetes, but it's only related to the other activity that's going on. For example, you're giving a patient steroids. Okay? Their glucose levels are going to be elevated, and you may be giving your patient insulin in the hospital or the care center while they are on this steroid treatment. It doesn't mean that they truly have diabetes. It just means that due to the other disease processes or medications we're giving them, we are going to treat them very similar. And then gestational diabetes, okay, that occurs in the 2nd and 3rd trimester for mothers who are unable to control their glucose levels. So usually hormones inhibit insulin and the ability of insulin to work with the cells, and therefore they are diabetics during that pregnancy. Once the child is born, usually gestational diabetes is resolved, but mothers who had gestational diabetes are at higher risk for type 2 diabetes. So that's a kind of a warning sign for us. Alright, we're going to talk about insulin and oral hypoglycemic drugs. So let's start with insulin. Okay, you've all given insulin. There's various types of insulin. Okay, the most common one is regular insulin. There are fast-acting insulins. Okay, and there are slower-acting insulins. So something, let me think of some of the names. Lispro is a very fast-acting insulin. PH you might have heard of, it's slower acting. Lantus is slower acting. So why is that important? Why is it important that when your insulin will start working in the patient's body?
Because depending on the situation, they may need something that works instantly, or they may need something that's going to work over time.
Okay, okay. So depending on the situation, if it's a more emergent situation, we're going to want an insulin that works faster. If we're trying to maintain them over a period of time, maybe a longer acting. But knowing that onset of insulin is essential because when that insulin starts working, their blood sugars could drop. So if I know the onset of a particular insulin is in 15 minutes, do I want to give that insulin before the breakfast trays arrive on the floor?
No.
No. Because if I give that insulin and the breakfast tray doesn't get to the patients for another 45 minutes, they're going to go have a hypoglycemic episode. So you need to know how soon when you can give that med based on when they're going to get their breakfast. That's the onset. So it's important to know the onset of these medications. Okay. You also want to know the peak. What is the peak when we say the peak of the drug?
it's doing the most that it can.
Okay? So that's when it has the biggest effect, the highest amount of the drug is working in the body. So if I know a medication peaks in 2 hours, I might want to come back and check on that patient at that moment, especially for your long-acting insulins. If you have an insulin that peaks 4 or 5 hours after you give it, you don't want to forget that you gave that medication. You need to come back and see your patient when it's peaking to ensure that they are not becoming hypoglycemic. Okay. The other thing we look at it for insulin is the duration. So the duration is how long that insulin stays in your body, how long it's effective. And that's important when we're looking at when we're going to be giving additional doses. So I included a couple charts in your slides that show different options for administration of insulin. So you will see patients on different types of schedules. So the first one shows we're going to give regular insulin 3 times a day with each meal. And then we're going to give NPH, which is a longer acting insulin, in the evening to take them all through the night. The idea behind insulin administration is to keep your blood glucose levels very stable. Okay? The body doesn't like when you have these peaks and valleys. Okay? You try to keep glucose maintain at a level, normal level. So if you look at the first chart, you can see how we are administering a second dose of the medication to keep our insulin levels at a normal rate so that our glucose levels stay at a normal level. Does that make sense?
Yes.
Excellent. So knowing the peak, knowing the onset, and knowing the duration will help you understand why a certain regimen is being used. The second one, you can see we're using multiple doses of NPH and less regular. And then the third one, we're using even more NPH to try to stretch the whole day and only giving the regular director. So there's a variety of ways that the provider will order this for you or prescribe it. This will help you to understand why there's different ways of doing it. So we talked about different types of insulin. We talked about the onset, the duration, and the peak. Those are things you just have to memorize. Okay? You need to just memorize the most common types of insulin and when they are going to have an onset, a peak, and how long they last, the duration. All about safety. So when do you want to give that med so that the patient doesn't become hypoglycemic? When are you going to check on that patient again to make sure they don't become hypoglycemic? And when is this medication going to run out so we need to make sure they don't become hyperglycemic? There are some combination insulins. So instead of giving regular and NPH separate, there are medications that combine those. And you may see those in your practice as well. So how do you administer insulin? Subcutaneous. Okay. Insulin cannot be taken orally, so don't let them drink it. Okay. The acids in the stomach will kill the insulin, so it won't have the effect you want. When you give it subcutaneously, where are sites for subcutaneous administration? abdomen, that's the most common.
The back of the arm.
Back of the arm.
Back of the arm, down here where all the flabby fat is. Okay? Those are your most common places. So subcutaneous uses a very small needle, right?
Yes.
Very short. What kind of syringe are we using?
An insulin syringe.
A specific insulin syringe, and those have the orange caps. We do not use a regular syringe for insulin. Even if you can get the right needle size, you need to use an insulin syringe. That's a safety thing. Okay? And so insulin syringes measure in units, where a regular syringe only has milliliters. You want to use that insulin syringe. Okay? How long does your insulin vial last once you start using it? Most of your healthcare facilities don't refrigerate it, so it lasts about a month. So when you're giving insulin, you must check the expiration date. It'll be written what day it was open and what day it expired. Okay. Insulin is a multi-dose vial, so you need to make sure that you are cleaning the stopper before you're putting your needle in, to ensure we're not injecting any bacteria into the vial. For patients who take insulin at home, they can keep it in the refrigerator and it'll last up to 3 months. Because they won't go through it as quickly as we do in our healthcare centers. Okay. The dose will depend on the patient, depend on the type of insulin, and depend on the blood glucose levels. Has everybody used a sliding scale?
Yes.
Everyone knows what that is?
Yes.
The NCLEX is coming out with more of these chart exhibits. So there might be a chart exhibit where you have to figure out how much insulin to give based on a sliding scale. So you want to make sure you feel comfortable reading that. What are we going to teach our patients about insulin?
They need to continue to eat.
Okay, so do we want them to eat bigger meals because they're taking insulin?
No. Smaller, more frequent meals.
We want them to, we want glucose levels to be nice and the same all the time. So we want to match the amount they're taking in with the amount of insulin we're giving. Okay. Many of your diabetics who are able to control their own or manage their diabetes very well, they will count the amount of glucose, carbohydrates that they're putting into their body, and based on that, know how much insulin to give themselves. Okay? Balancing what we eat with the insulin we're providing. Not getting any more insulin than you need, and not taking in any more carbohydrates than you're going to use. That is ideal. That is difficult for us in our healthcare centers. Okay? Better for an individual to manage their own. And that's really what we want them to do. So what we teach them is for them to be able to go and manage their glucose, manage their disease process independently, and not have to come back into the hospital or the care facilities. Okay. If you're giving two types of insulin, what do you need to know? Let's say you're giving NPH and regular. How do you draw those up in the syringe?
Clear over cloudy?
Clear first, then the cloudy. That's to prevent contamination of the short acting. What are some of the side effects of insulin?
Hypoglycemia.
Okay, hypoglycemia. How are you going to know if the patient's hypoglycemic? What are they going to look like?
Lethargic.
Confused,
Pale or
clammy
cold.
skin.
Cold, change in level of consciousness if it really gets low. The patient could lose consciousness, be confused. Okay. There's this thing called the Somogyi effect. So naturally our bodies, when we are sleeping, okay, the liver doesn't produce as much sugar. So the liver is working to bring forward glucose when we need it. And during the evening hours or in the middle of the night when we're supposed to be asleep, our natural clock says that you don't need as much glucose. So therefore it doesn't produce as much. You will find in some of your healthcare facilities that they ask you to take a blood sugar at 2 o'clock in the morning. Okay? And most of us say, well, I don't want to wake my patient up at 2 in the morning. But there's a purpose behind that. And the reason is that your blood glucose levels generally drop around 2 a.m. So if you have a patient who we gave insulin to at 10 or 11, and we know it might peak during the middle of the night, we're going to want to make sure we're taking that blood sugar. You also, even if it's not ordered, you want to go in and make sure your patient's okay. Sleeping nicely and never turning the lights on to assess your patient doesn't mean they're actually sleeping nicely. Right? It might be that their blood glucoses are really, really low and they have lost consciousness. You need to be concerned about low blood sugar at 2 in the morning. Right? There's also something called the dawn effect. So again, our body's natural clock is to produce more sugar in the morning. Okay? So to try to wake us up and get us going for the day, the body will start producing glucose, pushing out glucose to the cells. Okay? If you find that your patients have a really high blood glucose level in the morning before breakfast, that's an indication to ask the provider to increase their evening dose of NPH or Lantus to decrease that morning high blood glucose. Something to also think about when you're working the night shift. That lull you get at 2 in the morning is natural. And when you have extra energy right before the change of shift, that's normal too. So we talked about insulin. We talked about some different types of insulin. We know the effect that we want it to have. We want the insulin to push the glucose into the cell. When we say administration of insulin, it's what sites to use. We want to make sure we're rotating those sites. What needles to use, what syringe to use, how to mix the insulin. These are all things that you know. But those are the safety pieces to administration of insulin. After we give it, we are going to be assessing for hypoglycemia, knowing when our onset, our peak, and our duration is. And then the teaching piece is helping patients know how to administer their insulin to themselves. How to change their, and then there's diabetes as a bigger picture that we can do education on. One of the complication of diabetes is poor sight, vision impairment. What are you going to do for your patients if they can't see the little marks on that 100-unit syringe?
Do it for them.
So you're going to go to their house every morning and give them their insulin?
No.
What are some other options?
A dial up pin.
The pin.
A dial pin.
Okay. Okay, so there are pens, right? So they can dial in the amount of insulin they're going to give. So insulin pens. You can use pre-filled syringes. So maybe they have a daughter who can come over on Sunday and can fill the syringes for the entire week because this person keeps the same dose. Okay. Those can be stored in the refrigerator.
For 3 months.
The pre-filled syringes I probably wouldn't keep for 3 months. But the insulin's fine. It's just a matter if we contaminated it by putting it into the syringe.
Okay. What's the
They should be stored, though, with the needle up. So you want to get some kind of jar to put them in so that the needles are sticking out. Okay, how about some hypoglycemic medications? So these are oral medications used for type 2 diabetes. We're not going to go into a lot of detail about each one of these, but I want you to be familiar at least with some of the names of the drugs so that when you see them, you'll know what they are. So the first category of drugs is sulfurias. Okay, we don't use the first generation very much anymore because there's a lot of negative side effects, adverse effects. But we do use the second generations. So how many of you have heard of something called glucotrol or glyphosate? Yeah? Glyburide. Have you administered these drugs before?
Yeah.
Okay, very common medication. So this medication stimulates the release of insulin from the pancreas, okay, and increases sensitivity. It says peripheral tissues, but they're talking about the cells to the insulin. So this drug is going to produce more insulin, hoping that if we have lots and lots of garage door openers, one of them will work. And it's also making that garage door more sensitive to the insulin. So there's a little picture I gave to you. The glyphosate is opening up the cell door, helping to let the insulin out there. But what do you need to know about this drug? Okay. It's usually given twice a day with breakfast and dinner. Its onset is anywhere between 15 minutes and an hour. Because it's being taken orally, there's a wider onset. Insulin is very, very small. It's like, say it's between 10 and 15 minutes because it's sub-Q. Oral meds, it just depends on how quickly the body is able to absorb it. So anywhere but 15 minutes is the fastest to about an hour. Our side effects are going to be the same for all these meds. So hypoglycemia is the biggest one. Because this medication interacts with other parts of the GI tract, they do put some at risk for liver toxicity or hepatotoxicity. Okay? It's also excreted through the liver. If you have hepatotoxicity, what are some of the signs and symptoms you might see?
Jaundice.
Jaundice. What else does the liver do?
Cleans the blood.
So the liver helps to clean out chemicals in our body, and that's where you're seeing the jaundice because it's not removing the ammonia. Okay? The liver also helps with our clotting. part of the clotting cascade. So patients who have any liver damage are at risk for bleeding. So when you're taking these drugs, these are some of the things you might want to be looking for. The next medication we're going to look at is metformin. How many of you have heard of metformin? Glucophage. Okay? So glucophage is going to decrease the liver's production of glucose. We're going to stop it from metabolizing it, bringing it out. It's going to decrease the absorption of glucose in the intestine. So when you eat something, instead of it absorbing through the intestine into the bloodstream, this medication is going to leave that glucose in the intestine, and then you'll excrete it in your stool. It's also going to help the cells be more sensitive and take in more glucose. So it's working in 3 ways. The liver is not producing glucose. The GI tract is not absorbing as much glucose. And the glucose that is in the bloodstream, we're helping the cells take in more of that. Okay? This is usually administered once or twice a day. Okay? It does not generally cause a huge hypoglycemic effect because it's working more with the glucose piece. And the body, even though it's going to stop producing as much glucose from the liver and absorbing it through the intestines, if you need it, the body is going to override the drug. The big concern for this drug is renal impairment, kidneys, because it's excreted through the kidneys. So there are certain times when the provider will tell you they need to stop the metformin dose before a procedure. So what procedures would those be? Anybody have any ideas? If we know this can cause kidney problems, renal impairment. CAT scan. Okay, so not a regular CAT scan, but a CAT scan with IV dye, right? It's the IV contrast that is toxic to our kidneys. So if we're going to give something that's toxic to our kidneys, we don't want them to also be on metformin, which can be toxic to our kidneys. Any procedure in which they think the patient will become dehydrated or might lose a lot of blood, making the patient dehydrated, in a sense. Not exactly dehydration. But if you drop the blood pressure, if you lose too much blood, if you don't have enough fluid, the kidneys will take a hit. And when that occurs, you don't want them to be on metformin. So there may be a question, and definitely in your clinical experience, where you will come across a time when a patient is scheduled for a procedure and the doctor will say, are they on metformin? That is why. They need to be careful with metformin. Usually they ask you to hold it for about 48 hours. The next drug is Avandia. This is one of the newer medications. Okay, it reduces blood glucose by decreasing insulin resistance at the cell. So this is helping the cell be less resistant and more accepting of insulin. This drug also decreases the liver's production of glucose.
What does it do?
So it does 2 things. It decreases the resistance at the cell, so that the cell is more willing to take the insulin signal. and it stops the liver from producing so much glucose. So here it says, on the slide it says inhibiting hepatic gluconeogenesis. So that's the formal words for what I said. For not producing glucose from the liver. Okay, this drug is often administered in conjunction with another drug. So given with metformin or given with one of the sulfurias. It may take several months for this drug to start working. So this is not a quick fix. And our concerns with this drug is it can cause you to retain fluid. So if you have heart failure, it puts you at risk. If you have any sort of cardiac disease, this is not a good drug. Is everyone caught up? We ready to go on?
Yes.
Alright, Januvia. Okay, another newer drug, and there are new drugs that come out all the time. So again, I can't talk to all of them. So we're just going to touch on a few. Okay? This drug works a little differently. This drug inhibits hormones, in a sense, or the release of hormones. So these hormones are released when the body takes in food from the stomach. So incretins, they're released from when you take food into your stomach. These hormones are released, and what they do is they signal the pancreas to start producing insulin because you just took in food and it knows it's going to need insulin for that glucose. So what this does, it helps increase that hormone so that the pancreas produces more insulin than what is needed for the amount of food that you took in. So it's really signaling the pancreas to produce more insulin. It's just going about it in a different way than the other medications. This medication, again, you're at risk for hypoglycemia if we're producing more insulin than needed. So for all of these oral hypoglycemic medications, they all work in, for the most part, 3 ways, right? 4 ways. So they either make the pancreas produce more insulin, they tell the liver to stop producing as much glucose, they work on the cell to make it accept the signal that it's getting it from the insulin, or it works in the GI tract so that you don't absorb as much glucose. How it's working in each individual drug is not as important when you're administering it as understanding the various side effects that can occur. So we know with these patients we'll be looking for hypoglycemia. We know it has an impact on the liver, so we want to make sure we're following our liver functions and assessing for any sort of liver failure. Okay? Because they're taken in orally, they can have all the normal side effects: nausea, vomiting, diarrhea. And then metformin is the big one to remember for renal failure. Okay, so you don't have to try to memorize each individual drug, but understand how the medications are working and the concerns you have while administering these medications. So what are you going to do if a patient becomes hypoglycemic?
Give them orange juice with sugar.
Okay? Excellent. So if they are alert, if they are awake, you can give them something to drink. Orange juice, it works really well. If they, you will then check their blood glucose, and if it's still not coming up, you can give them more juice. But giving them juice is just a quick fix. So what are we going to follow that orange juice with? Food. Okay? Even if it's just crackers, peanut butter, we want some more complex carbohydrates to be taken in. That's going to keep that blood sugar up for a longer period of time than orange juice. Okay? If your patient is not responsive, what are our options?
Glucagon.
We can give glucagon. Absolutely. Okay, so we are going to inject the patient with glucose. There are also sublingual sugar that we can give the patient. So there's a variety of ways to get their blood sugars elevated quickly. The big thing to remember is that if your patient is not conscious, do not try to give them juice. Okay. You think that's silly, but it happens. I have walked in and seen people trying to force their loved one to drink something when their loved one was clearly not conscious. Okay? Not with it enough to be able to swallow. And we do not want orange juice in our lungs. Okay? That's not going to help your patient. Okay? So we're going to administer some form of sugar to bring their blood glucose up, and we're going to follow that with more complex carbs. Then we're going to evaluate what their insulin regimen is.
Hey, we can't hear you.
We lost you.
What was that?
There you go.
Tell her we didn't hear nothing she said.
We didn't. We stopped hearing you.
Okay, can you hear me now?
Yes.
Okay, I heard some weird noises too. Okay, so we want to, after we get their blood glucose up, evaluate why it went down so we can prevent that in the future. Alright, some basic nursing management for diabetics. Prior to administration, you want to know what their blood sugar levels are, what other medications they might be on, and the type of insulin or oral agent that they use. Okay. After we administer drugs, we want to evaluate their blood sugar. So we may ask them to keep a log so we know if this medication is working. We can also use a hemoglobin A1C to get a snapshot if it's working over the 3 months. Okay? We talked a little bit about administration of insulin already. Oral medication is just making sure you're giving it at the time it is prescribed to be given. Right? The drugs are either supposed to be given with food or without food, and the pharmacy will schedule those times, but you need to make sure you're following the times scheduled. Patient education. Patients need to know the signs and symptoms of both hyperglycemia and hypoglycemia. And not only the patient, but the patient's family or whoever they live with should post those up on the refrigerator. Okay, if mommy looks funny and this is going on, what is the child supposed to do? Because when they become hypoglycemic, they're not going to be able to think for themselves. So we need to have somebody else who's there who can respond when they start to act weird. Okay, how to administer the medications, how to store the medications, making sure they're rotating sites. Okay, how to use a sliding scale. And when their blood sugars may become higher. So, stress. If they have a big test coming up, you all have a big test coming up,
Of course.
your blood sugars are going to go up.
There's been a
So if you're a diabetic, you have to be aware of that. If you have the flu, you'll have blood sugars go up. Different medications can make your blood sugars go up. So if you have a patient who's diabetic, we need to make sure we're educating them about that. Patients should understand the type of diabetes they have. We talk about diet, exercise, wearing an alert bracelet.
I got a question.
Yes,
Why if they have the flu can their blood sugar go up?
so anytime the body is stressed, not in the sense of you feeling stressed, but physiologically stressed. So if you have an infection, the body is working harder to fight off that infection. So it produces more glucose. The cells will need more sugar in order to fight off the infection, so the body naturally produces more sugar.
Okay.
It pulls it out of all of our stores and starts using it up. And if you don't have insulin to properly use that glucose, they become hyperglycemic.
Okay.
Right? Patients need to be taught how to prevent hypoglycemia. So carrying a sugar source, making sure they're checking their blood sugars. Beta blockers. Okay, if a patient's on a beta blocker, this is an antagonist, means it works against many of our oral hypoglycemic drugs. So we need to be aware of that. You may also see someone who they give a beta blocker to if they are hypoglycemic because of an overdose on their diabetic medication.
What did you say it works against?
Beta blocker does what again?
It's an antagonist to our oral diabetic meds. So an antagonist means it works opposite of. So if a patient has taken too many or their blood sugars are too low because of taking oral diabetic medications, we can use beta blockers to reverse that. So some of our diabetic medications, have very long half-lives. And so you're not going to just be able to keep pumping sugar into them. They may give them beta blockers. But if you have a patient who has heart failure and is taking a beta blocker, they're going to need more diabetic medications because the beta blocker is going to block some of the function of that diabetic med. Does that make sense? They're on both. They're going to have an increased dose of the diabetic meds because the beta blocker is going to have a negative effect. Yes?
Yes.
Do we need to take a break?
No.
Does everybody agree or just one person?
Do you need a break?
I'm fine.
Okay. Let's go.
Alright. Any questions on insulin, diabetes management, diabetic drugs?
No.
Alright. Moving on, respiratory drugs. There's a whole variety of respiratory drugs which you most likely will be giving or have given as a nurse. first one, antihistamines. So antihistamines are chemicals, okay, and it's going to decrease the inflammatory response. We often give these for patients who have allergic rhinitis. Do you know what that is? Allergy symptoms. When your nose runs and your eyes run and your throat gets itchy. Histamines will help with that. Okay. Antihistamines can also work when you have bronchoconstriction. Okay, when your bronchus close up due to an allergic reaction. And this is going to help dilate or open up those bronchi. There's different generations. Okay? The first generations cause you to be sleepy. Second and third generations, not as much. So, we give these meds to help with allergic responses. They can be administered orally or intravenously. Histamines are not used for anaphylaxis. So even though it helps with the allergic response and it helps with it reverses bronchoconstriction, it's not a emergency drug for anaphylaxis. What are our side effects? Generally just drowsiness, dry mouth. What do you want to teach your patients?
Drink lots of fluid.
Okay, drink more fluid. Many of your antihistamines are found in cold medicine and sinus medication over the counter. So you want to teach your patients to read the labels of their medications. Over-the-counter cold medications, they like to put all sorts of different drugs together. So if you're already taking an antihistamine and then you take a cold medication that has more antihistamine in it, okay, you're going to have more of that dryness that you don't want, and irritability. All right, intranasal corticosteroids. Intranasal meaning that we are spraying this right into your nose. Okay? Why is that better than taking a pill? Faster. It gets right to the source. Okay? It also has less side effects because it's not having to be absorbed and go through the whole body. It's like a topical medication is better because it goes right to the source and doesn't have the systemic side effects. So corticosteroids decrease inflammation, okay, decreases edema. The most common drug, or one of the ones that you'll see, is called Flonase. Imagine you've heard of that one, seen commercials for it. So Flonase works right at the source. Sometimes you'll get some drying of the mucosa, bloody noses as a side effect. This is also a corticosteroid. So even though it has minimal systemic effects, you have to remember that steroids decrease inflammation and can mask the sign of an infection. So if they have a sinus infection and they're taking corticosteroids, Flonase, they're at higher risk for infection, and you may not notice that you having the symptoms of an infection because it'll be sort of covered up by the fact that we are taking away all the inflammation. Okay, this drug often will take several days to start working. So you won't be able to, it's not an emergent type of thing. Most of the literature on this says you need to take it consistently every day. Okay, the next one is decongestant. So there's nasal decongestants and there's oral decongestants. You can take it in a variety of ways. This is going to cause vasoconstriction, so the little blood vessels in your nose are going to shrink or close up, so decreasing fluid from coming to the nose and the mouth, so that it decreases secretion. Some common types are Afrin, Sudafed, Atrovent and Comdivent are taken often as inhalants. What are our side effects? Our big concern with decongestants are cardiac. So these can cause an increase in blood pressure, an increase in heart rate, and an increase in glucose production. There's use of Sudafed illegally to produce those highs, and if you think of that in decongestions, that you'll be able to remember the blood pressure and the heart rate issues that go along with it. So if you have a patient who is in the hospital for an infection and is tachycardic, giving them one of these decongestants is going to create their heart to race even faster, which could create problems. So respiratory therapists usually give your Atrovent and Comdivent, and they may come to you and say, well, we held the inhalant because the heart rate is 102. So as the nurse, you're going to have to make clinical judgment. Is giving the med more valuable, knowing the heart rate will go up a little bit, and can the patient tolerate that? Do we need to call the provider and see if there's an alternative medication that will help with the respiratory congestion without raising the heart rate? Any questions about that one?
No.
Antintrusives, expectorants, and mucilates. Antintrusive, these are to suppress your cough. So this is good. This is a good medication when the cough is unproductive or the cough is uncomfortable for the patient. This is not something you want to use when we want them to cough. If you have an infection going on in your lungs and we need to get all of that mucus out of you, you don't want to give a cough suppressant. We want to encourage them to cough. So this is usually when it's a dry cough, or when there's no, that the cough is not because of something in their lungs. Expectorants are what you want to use if the patient has mucus in the lungs that we need to get out. So this is going to liquefy or cause those real thick mucus to thin so that it can more easily be coughed out. This is guaifenesin. I'm sure you've heard of that, or Mucinex. Okay? This drug does not have it has very few, if any, side effects, but it is found in over-the-counter medications, so you want to make sure that they're reading their labels again so that they're not mixing drugs. We also want to teach patients to take in more fluid, not strictly with Mucinex, but with any type of respiratory infection where they're trying to get out these secretions. Increasing fluid intake is going to help with that. This is going to be pulling fluid actually from the bloodstream to help loosen things up. The next one is a mucolytic. So this is Mucomyst. Okay. It's going to also help thin out that mucus. Mucomyst is not used quite as often as you will see guaifenesin. Guaifenesin is a little safer drug to use. Mucomyst is often given as an inhalant for patients who have really, really thick, viscous kind of secretions. It can be given orally as well. Its secondary action, it actually provides some protection for kidneys when you're having maybe a CAT scan with contrast done. So you may be prescribed orally for that. Personally, I have given it intravenously, though it was in a trial section, and they were giving it for Tylenol overdoses, which was interesting. It has a rotten smell. It kind of has a nasty smell. So if you're giving it liquid and you have to drink it, you might want to mix it with something, some juice, because it's very potent. Any questions about those? Bronchodilators. And there's 3 types of bronchodilators that we'll go through. The first one is a beta-adrenergic agonist. So this is going to help those bronchi dilate. Exactly what it says. It's a bronchodilator. It helps the bronchus open up, allowing air to move more easily through. So this is given if you have a patient who's wheezing, so their bronchus are really closed, and when the air goes through, it causes that wheezing sound. This is going to help open up those bronchi. So patients who have asthma, patients who have COPD will often be on these type of medications. The thing to know about beta-adrenergic agonists is that there are short-acting and there are long-acting. Short-acting can be used as rescue inhalers. So that would be something like albuterol. When the patient is having that asthma attack, status asthmaticus, you could give this inhaler and it will help relieve those symptoms. The long-acting beta agonists, okay, are not rescue inhalers. This is something like Ceravent. It has a very slow onset and a long duration and should be used on a regular schedule dosing to prevent the symptoms from occurring. Remember when we talk about beta agonists, there's beta 1 and there's beta 2 in our bodies. Beta 1 is the heart, beta 2 is the lungs and other organs in the body. So you have one heart and you have 2 lungs. Beta 1, heart, beta 2 is for the lungs. 2 lungs. Because these drugs are beta agonists, they can have an impact on the cardiac system as well. So you need to be careful when administering these medications. Checking their heart rate, checking their blood pressure. Because if those are elevated, then you do not want to give these medications. Now, we always have to make a clinical judgment. The patient can't breathe because they have bronchoconstriction, which is causing them to be anxious, not getting enough oxygen, and therefore their heart rate and blood pressure are up. Giving them this medication is going to help them to breathe better, get more oxygen, be less anxious, their heart rate and blood pressure are going to go down. Okay? So, just because they have an elevated heart rate does not mean we hold this medication. You as a nurse have to be able to make a clinical judgment on if it's safe or not. The side effects of these drugs are tachycardia, palpitations, cardiac dysrhythmias, hyperglycemia. The next bronchodilators are anticholinergics. Okay, again, bronchodilate or dilating those bronchioles. You see this much more frequently used in COPD patients, rarely used in asthma patients. Common ones are Atrovent, Spiriva, very commonly associated with COPD. So anticholinergics, and you may not remember what cholinergics are, but cholinergics have to do with fluids. Okay, it's a chemical in the body. It creates you to have your eyes to water. It creates fluids in your digestive system. It helps you with urination. So if we are anticholinergic, we are blocking those things from occurring. So along with bronchodilation, these are going to have side effects of basic anticholinergics. So dry mouth, dry eyes, you can have urinary retention. Anticholinergics can be used as a rescue inhaler, and they can also be used as a routine inhaler. Any questions about that one? we're moving fast, so if you need to stop me, please do. The next medication, methylexin derivatives. The most common one here is theophylline. Okay? This acts like caffeine in the body. Okay, again, a bronchodilator. It's used for more chronic, stable asthmatic patients or COPD patients. Okay, this is not used as an emergency medication. It's used for long-term treatment. Okay, it's not an inhalant. It's given orally. And it acts very much like caffeine. So your side effects are going to be things like nervousness, irritability, tachycardia, palpitations. Think if you were high on caffeine and had the jitters, that's sort of what these patients can look like. Because of that, we want to teach our patients not to drink any caffeine products. You don't need a cup of coffee on top of this drug. You also want them to increase their fluid intake. Because the caffeine effect is going to be similar to other organs in your body. So you want to make sure you're bringing in those extra fluids so they don't become dehydrated. Any questions on the bronchodilators? So 3 types. Okay. We got our theophylline, we got our anticholinergics, and we got our beta agonists. Okay. With all of them, our biggest side effect of bronchodilators are cardiac. Heart rate goes up, blood pressure goes up, glucose goes up, the irritability. They all work a little different, but for the most part, you're going to get those same side effects. Some of them are rescue, some of them are for long-term treatment. So you need to sort of know the difference in those. Alright, you ready to move on?
Yeah.
Yes.
Alright, anti-inflammatory drugs. You got 3 types here too: corticosteroids, mast cell stabilizers, and leukotriene receptor antagonists. So corticosteroids. I have no doubt that you know all about steroids. Probably been pushed in your head over and over again. So decreases inflammation, also decreases the immune response. These can be inhaled, they can be given orally, and they can be given intravenously. Of adverse effects for these is always making sure that it is the immune problem. Patients are at high risk for infection. So we want to make sure that we are educating our patients about signs and symptoms of infection, that we're doing good hand hygiene, good oral hygiene with these patients. If they're doing the inhalant, we like them to use a spacer. Do you know what a spacer is? Yeah, so between the inhaler itself, there's like a tube that they use. Okay? When teaching a patient to use an inhaler, we want the medication to get into the lungs. So doing a quick spray just sprays medication all over your mouth. It doesn't help it get into the lungs. The idea is to slow and to inhale all that medication down into your lungs. The spacer helps with that because it makes the liquid from the inhaler become aerosol within the tube, and then you can inhale that in. if you have corticosteroids up against the tissues of your mouth, it's going to kill your normal bacteria. It's going to kill your ability to fight off infection. And patients are at risk for what we call thrush. You know what thrush is? Yes. It's yeast. Yeast that grows on your tongue. It's white and gross looking. So whenever someone takes a corticosteroid inhaler, afterwards you need to have them swish and spit. They need to clean their mouth. Other things, we want to make sure we're assessing for infections. Okay. We're assessing for any systemic infections, especially if they're taking it orally. Corticosteroids, especially oral corticosteroids, need to be tapered off. You do not want to stop them immediately. So usually we will start with a higher dose, and then over a few days you'll go to a few less, and a little less, and a little less to taper it off. If you stop taking the steroid abruptly, you will have an adrenal crisis. What that means is that when we give steroids to a patient, their adrenal gland says, well, I don't have to work anymore because you're giving it to me. So then we stop giving it to them, and it doesn't give the adrenal glands time to kick back in. Okay? We need to taper it off so the adrenal glands start to produce on their own. The next one is mast cells. Mast cell stabilizers inhibit histamine from being released. And histamine, as we said way back when we talked about antihistamines, are what cause all of those cells to rush to your face and causes a runny nose and runny eyes and your throat to get all swollen up. So this medication is going to stop the release of those chemicals. This is not given for an emergency. This is a slow acting. All of us of our steroids are anti-inflammatory drugs are slower acting. And these are not emergent drugs. Alright, the last one are leukotriene receptors. This is something like Singulair. So these are, again, leukotrienes are mediators of the immune response. And so we are going to be blocking these mediators to suppress that immune and allergic reaction, or the response of the body to an allergen. With this medication, you're going to want to increase fluid intake. Again, not an emergency drug. This is something they're going to take slowly. It'll take over multiple days to help prevent a reaction. Singulair or leukotriene drugs are usually prescribed and taken at night before bed. That's because your leukotrienes are more active in the evening time, in the nighttime, so it helps to block them better than if you were to take the drug in the morning when you have a lower release of them from the body. Any questions about the anti-inflammatory drugs?
No.
Any questions about any of the respiratory drugs?
No.
Has this helped? Or am I just repeating stuff you already know?
Yes.
Yes to which question?
Yes, it's stuff we already know.
Okay. So when Ms. King told me that you guys were struggling, I think you have the knowledge you need. I think you really have what all the pieces that you need to be successful on the test.
Our scores don't indicate that we have all the stuff that we need to.
So what areas are you struggling in? Is there a particular section? Because I can keep throwing things at the wall, but if I know where you need me to focus, that might work better for you.
Initially, we told them farm and med surg because we really didn't get any farm at all. We did 5 drug cards, and that's all we've done.
Okay.
So we don't have any farm.
So I can continue with some more pharmacology. I think going through some cardiovascular meds might be helpful because those are very common. That form I sent you, I have several of those, and I can give more of those to you if you want to use them as a worksheet to sort of pull out the main concepts. Is there particular areas in pharmacology that you finding that you're struggling on in ATI?
We haven't had any farm.
I'm sorry, what was that?
We haven't had any farm.
You haven't had, you didn't take a pharmacology ATI exam?
Yes, but we didn't do good.
Right, so what areas on that did you struggle with most?
All of it, because all we did was 5 drug cards.
So you did drug cards when you started, but you've been administering medications throughout the program.
We mostly
Insulin?
give insulin and Lovenox.
Okay. So if we do one of these next week, where do you want me to focus? Do you want me to focus on cardiovascular drugs?
I mean, the scary thing is we do our predictor next week. So we were I guess we just had like a different expectation going into this because they said that you did this with other people and you had like a 90% pass rate. So we just, I think, expected something different because of the people here know what we're struggling with. They see it. But
Right,
I
and
mean,
you have the same, you are expressing the same concerns the other campuses did. So what I need to know is if you want something different, what do you want?
I mean, the cardiovascular thingy would be a good idea.
Okay.
I mean,
I
but
mean,
we take
if you want to send me your results from your farm ATI, I can look and see areas where you were struggling with, or what areas they're focusing on.
we could send it. How soon could we get the cardiovascular information?
So it depends on a lot of it's on your schedule, because your days are full and you have clinicals. So it's just finding time when I can send you my slides immediately. But in order for us to have a conversation, really just depends on when you're available.
Okay, so if we're doing the cardiovascular, are we still getting med-surg next week? Because those are the 2 main things that we're concerned about.
So mixed in with some of the I can sort of do a combo of cardio and med-surg cardio and drugs for cardio. We can touch base on a lot of the med-surg stuff. I think is falls under more of your
So you're saying,
for a vacation, right?
so, yes, ma'am, and you're saying that you can give us some more of these fill in the blank things?
Absolutely.
You want to ask anything else? I ask about this?
So why don't I'll send you what I have right now for cardiovascular farm, and then let me go through it, and I'll put in some med-surg content as well. So then when we talk next week, we can do both some med-surg and some pharmacology, but you can have everything I have right away so you can start looking through it.
Okay, just a question that is kind of off topic, but all the stuff that we signed when we entered our program, how do we get a copy of that?
So the registrar has your official file, so I'm not sure if there's some form or something process she has, but I would ask Maria.
Okay. Maria. Oh. I think somebody stated that we were told we couldn't have that stuff.
So I don't know what the process is. So did you speak with Maria, or you're just secondhand hearing that you can't have it?
Somebody else has spoke with Ms. Shelton, I guess. I don't know where they got that from.
Okay, so I would go, personally, to make sure you hear it yourself, to find out if there's a reason why you would not be able to get a copy of your file. And then if they have a good reason, then you'll know. If they don't, then let me know, and I can see if I can find out.
Are we gonna see you before we take our, are we gonna see you before we graduate?
Probably not.
Probably not.
No.
If we graduate.
Your concerns are valid, and I want to help you. But I can't teach everything in a short period of time, so we have to work together and figure out how I can help you do your prep and what you need from me to help explain and reteach or teach to you. So if I hand you what I have, then you can better provide me with, okay, I can read this and I get this, but these are the areas that we really need you to focus on and talk us through.
Well, I guess you could just teach us all of farm because we've never been taught any. So it's not our fault.
Well, you had a pharmacology class. You're just saying that you don't.
I mean, we had the class, you are correct, but we did not get taught. We didn't start nursing school till level 3
When Miss King came.
and
This is pointless.
Like, we were taught to memorize the answers to the test, not memorize the drugs and what they do and all that.
And I guess that's kind of our frustration, because now we're here at the end, and we appreciate the help, but it's kind of like, okay, we're going to help you, even though you take your predictor in a week, and then you have to cram, not to mention we have, like, tests and stuff we still have to do, and everyone feels like we have the proper foundation when we actually have no foundation at all, and we're going into this not even, I mean, even our capstone coach doesn't even know what's going on. Like, it's just nobody's on the same page, and we're frustrated because all of us are in this because ultimately we want to graduate. We want to be LVN nurses. We are spending $26,000 that's why we're here. We don't want to come back another 12 weeks. We don't want to remediate for 12 weeks and then still not get to take. I mean, it's extremely frustrating. And everyone expresses that they get it, but I don't think they really get it because we have not. You have your own job, Dr. Little. You have stuff you have to do. So you cannot do this every day, all day with us. Unfortunately, this every day, all day is what we need. So we're in a situation.
So maybe there's a way we can use more than just one person to help you. And I know you have your full classes as well. Miss King is currently teaching pharmacology, and I know she has the expertise to assist with helping you to learn some of these concepts. So maybe she could do a session with you on another day. Are there any other instructors you feel there that would be beneficial to working with you?
One of the students is saying, like, what you just did right now is what we need for every class, right? Every drug class. Like, one of our clinical instructors just taught us about Picmonics, and I can't speak for anybody personally, but with her just giving me that information, there was a huge increase in my pharmacology score. I didn't know anything about it.
Okay.
So, I mean, it's just like we're getting these resources, but we take our predictor next week, and then clinical class, all this extra stuff, and then live review, and then boom, predictor again. So we don't have a lot of time to prepare.
Right. So let's use your time as wisely as we can. Do you feel right now that your clinical instructors are able to help you with some of this learning? You said you learned something in clinical.
No. Not
Not all of them. Okay. Are there some that are?
We're just there doing patient care. Like, if a lot of the nurses over there at some of the sites I go to, they don't even wait for us to let us do anything. They start pulling the medication out themselves. So if we do not draw the medication up ourselves, I will not give it. So I'm not learning anything that way, and they're just getting ahead. They're not doing it properly. They're lazy about it, and that's teaching us to be
Talking about the staff.
staff.
At the
And then, but the teachers are just sending us out to do the, just to go out with our nurse. That's who we're supposed to be following. So they're not really teaching
we can
us.
adjust that. If you feel that if you feel that the faculty are competent and could provide you with more education if they were directed to do so, that's what I need to know. Or do you feel that your instructor, because you've had many instructors through your program, are not strong enough to help you?
If I have to do the extra 12 weeks of the green light, I definitely don't mind because I could use the extra teaching. But I feel like we've all busted this whole 4 levels, even whenever we weren't being taught, we were learning some of the stuff on our own. I don't think that should be a factor as to why we don't graduate. I mean, we could have an A in the class, and then we don't make a 75 on the predictor, and we have to repeat the whole class.
That is true. That is the current policy.
That's
Now,
ridiculous.
I'm not asking about that. I am asking about your current clinical instructors.
I mean, but
You are with them for long days. So if I instruct them to bring you into a conference room and to work on pharmacology and med-surg concepts, so we're using your time wisely, do you believe that they could do that effectively?
At what point would we be able to do that? Are you saying at a clinical site?
At the clinical sites, in your individual small group, you must have neuromuscular drugs with you.
Okay, I mean, and maybe if we had somewhere to go, because at our clinical sites, they don't let us use. We can't go, first of all, at the plaza, we can't sit for too long, even if we're doing our paperwork, because they have an issue with that. At Grace, they hate us at Grace, so we don't even really get to help at Grace. So
You don't want to sit down.
it would be beneficial if we could come back to school, even if we just came back to school, because some of us have self-taught, like reading our ATI books. Even if we could just come back to school and read our ATI books on our own, because we're used to self-teaching, that would even be beneficial. But doing it at the site isn't going to work, Dr. Little, because the sites don't even want us there.
Okay, and the sites don't offer you where do you do post-conference if there's nowhere to go?
outside.
The chapel, you have to do it at the chapel, we do it, sometimes you have to do it outside. It just depends on what clinical site you're at. Sometimes we do it at the ER, at the hospital. It just depends on where we are.
Okay. All right, so let me work with Ms. King with that piece. As far as the faculty, though, you're confident in your faculty members if they have the opportunity.
Two teachers that teach us. That's Miss King and Miss King. Miss King and Miss
We're confident in Miss King and Miss Robertson, because Miss Pitts is extremely busy with the other levels. So in terms of the people that we're with all the time, we are comfortable with Miss King and Miss Robertson in terms of teaching us some extra stuff, maybe to get us close to a 75. Okay.
Alright, so let me work with Ms. King and let me see what I can put together for next week so that you have some additional opportunities to prep before the exam.
Are you talking about before the first one or before the last one?
The first one, I heard you're taking it on Friday, is that not true?
Yes, ma'am.
Yes, so during the week, and then we're going to see how that works, and if you liked it, and even if it's not enough, it's a start, and if it's working, we will continue those activities for the next few weeks.
Okay, so on Tuesday is our clinical day. They're giving us we're doing a focus review, so kind of like this, but we're going to be with Miss Robertson, who is somebody we believe that can help us with our ATI books, just getting it in as long as we can. Is there any way that you could, if you're going to talk to Miss King to see about doing that, is there any way, because we're doing it on Tuesday, we would normally be
We have that scheduled on Tuesday.
right. Well, I don't know if it's set in stone, but that's what we were talking about today. And, okay, Tuesday is set in stone. If is there any way that we could do it Tuesday? Maybe you could talk to Ms. King, working that Wednesday, then we do whatever you're gonna do with us Thursday, and then we take our predictor on Friday.
That sounds like a plan. I need to follow up with Miss King and see what she's already scheduled for you, and see if there's an opportunity for me to either come in and help out more, or if she already has people in place to do that for you.
Okay, because I think on Wednesday we just have a regular clinical day. I know they were letting us do it on Tuesday, so maybe if you guys could maybe work that out, because that would kind of be like 3 days of preparation, and then boom, the predictor. Because whatever we're taking in on Thursday, I don't feel like we have enough time to retain it to come back and, you know what I'm saying, apply it completely on Friday.
Okay, I agree.
Anything else?
So maybe even I can provide something on Tuesday, and then our Thursday can be, we can look at some test-taking techniques or other types of things to prep you for Friday.
Yes.
Yes, ma'am.
Okay, let me talk with Miss King and see what we can put together.
Okay, and then if you said for us to talk to Maria, and if we can't get our paperwork from her, then what do we do?
So I would ask the reason.
Okay.
See if you can get it. I mean, it doesn't hurt to ask. Ask why. Why? And if you don't get a good reason, let me know.
Okay, then I guess we'll head on over there and get that figured out. Thank you for all your help.
Okay. Thank you, everyone.
Thank you.
Thank you.